Good afternoon, everyone. My name is Roshni Matthew, and I co-chair this COVID-19 in Children seminar series with Dr. Alan Schroeder. Today we have an excellent session ahead of us, and Dr. Schroeder will introduce the speakers in a minute. The code for this CME is on the screen, and we've had the wonderful pleasure of hosting this weekly now since October. We will here on be going to a monthly cadence. So the next session will be on March 11th, and it will be an open forum session, and we will have a link to put in your questions, to submit your questions beforehand. From here, you can please put in your questions as usual in the Q&A. And if you're seeing the live transcript, you can disable it if that is distracting to you. With that, I will hand it over to Dr. Schroeder.
Thank you, Dr. Matthew, and thank you all for joining today. We like to think that our transition to a less frequent cadence here is driven in part by some of the optimistic developments around this pandemic, but it's obviously not over, and there's still a lot to talk about. Clearly, as we evolve into our understanding of what immunization will mean for children and school reopening and lots of lingering questions. So we will be addressing those types of issues monthly with various guests, including Dr. Maldonado. And since this is our last sort of weekly one, I want to just do a special thanks to our entire committee, but particularly to Ingrid Garnica, Allison Guerin, and Serena Tom, who's just come back. Really incredibly helpful in their support technologically and administratively of this weekly series. We could not have done it without you guys, so thank you so much. And I am very thrilled to introduce, you can unshare now, thank you. I am very thrilled to introduce today's guest. Dr. Natalie Pageler is a professor of pediatrics here, is a colleague in pediatric critical care, and is our chief medical informatics officer. Is a Stanford lifer. I think you all know her well, and she will really lead this session, but our additional guest will be Dr. Rajdeep Pooni, who is an instructor of pediatrics in the Division of Pediatric Rheumatology, and as a fellow really did some pioneering work, as we will hear about today, in the rheumatology population with some of their adolescent patients. And last, and certainly not least, it is really fun for me to welcome back Dr. Chris Longhurst. If you don't know him, you should. I first met Chris, just gonna take a little bit here. I first met Chris when he was starting internship at residency. That was what, a couple years ago, I guess, Chris, maybe 20. And he was looking for furniture, and I had some leftover, I think it was a couch or a lazy boy chair. And it was pretty gross, but he took it and I think had it for years. And Chris has come a long way since then. I think he's mostly buying new furniture, but has also really evolved professionally. Had left us a couple of years ago onto the University of California, San Diego, where he is the CMIO of pretty much all of Southern California as I see it. He is the Associate Chief Medical Officer as well, a professor of pediatrics, and really doing great and innovative things. So really nice to have Chris back and see you. So Natalie, I will let you take it from here.
Thanks, Alan. And yeah, we're all very excited to have Dr. Longhurst back with us. I think you'll be hearing little bits and pieces about him as we go, but he gets to wrap up the session, so he gets to give us all payback. So it's my pleasure to kick off this talk, and I really am just kind of kicking it off and giving an introduction to two great speakers who will be talking about some very exciting and interesting aspects of how telehealth and clinical informatics have played a role in COVID, with some specific considerations around children. So I'm going to do this overview. Raj will then take it from there and talk about all of her great research in pediatrics of specialty telehealth during the COVID pandemic. And then finally, Chris is going to wrap up with some amazing work that he's been doing with throughout the state of California around exposure notification systems. So just a minute, I've got the forum to highlight what the field of clinical informatics is, and to again, highlight Chris a bit here, but so there are many different definitions of applied clinical informatics. This is the one I usually use. It's the implementation, optimization, and evaluation of health information systems to improve the quality of care, efficiency of practice, healthcare experience, and ultimately patient outcomes. And in 2011, clinical informatics became an official board certified specialty. And many of us sat for the initial boards back in 2013, and including Dr. Longhurst and myself. And Dr. Longhurst helped found the very first clinical informatics fellowship program in the nation here at Stanford, and served as the first program director. And we have come a long ways from that time. So this picture may not be the best picture of our fellowship, but I thought it was apropos for COVID. This is a Zoom summer series session this past summer, where we had all of our former informatics graduates come and speak with our current 8 clinical informatics fellows. And these fellows are truly doing amazing work and jumped into the COVID pandemic in unbelievable ways. And most of the work that I am highlighting, they were heavily involved in. So if you want to find out more about the fellowship or clinical informatics, please reach out anytime. So as I mentioned, Dr. Longhurst helped start the fellowship and is a leader in the field, and apparently never sleeps, because he and his group were the first group to actually publish on all of the work that needed to be done in clinical informatics when the pandemic first hit. So this is a paper that came out, I think it was actually even originally released in March, so right at the beginning of the pandemic, from UCSD system, talking about all the different ways that the informatics and technology teams got pulled in to help cope with the pandemic. And the story they write is it's a very well written article. I highly recommend it, but it is also very typical for what was going on across the country. So same types of things that they were dealing with was what every health system was dealing with. And this is one of their tables, which gives you a quick list of just the EHR related items that had to be done in those first few weeks as the pandemic hit. So everything from creating screening systems to creating order sets to help with the treatment or the testing of COVID, to creating templates for documentation, to creating all kinds of new reports and analysis to help track who was positive and where they were and who the caregivers were and who was allowed to visit. Then to, of course, the communication channels and telehealth, which you're going to hear a lot more about. So just this is, I think, gives you a quick idea of how many different pieces were happening simultaneously. In addition to the EHR pieces, our informatics teams are tightly integrated into our IT information services team, and there were multiple other technologies that came to the forefront. So communication was huge, both for communication and training for all of our staff and providers. We immediately had to get up intranet sites with updated testing guidelines, PPE guidelines, all of the information that was coming out related to how to cope with COVID. We, because of the massive telehealth explosion, had to get up lots and lots of training, automated virtual trainings, training sites, tip sheets, everything to be easily available. And then also set up automated mass secure messaging. I think for those of you who are at Stanford, you probably remember those somewhat annoying alerts that we would get every so often, or every few hours on our hospital phone saying, have you checked in? Do you have symptoms? Those kinds of things. But it was a great way to get out messages to everybody who was clinically active and make sure that we were doing the kind of early check-ins that were part of the pandemic response. Similarly, communication with patients was a huge issue. Again, relying on websites for educational information to make it available to anyone, but then also looking at bulk communication in the form of emails or portal messaging or even text messaging. Remote work, as you all know, was a huge part of responding to the pandemic and trying to encourage social distancing and minimize exposure. So mass amounts of our, anybody who didn't need to be in person was encouraged to work from home. And that meant for our technology teams suddenly completely transitioning the way we supported our staff. So had to massively expand our network and licenses for our virtual private networks and virtual desktop imaging, had to provision equipment for people to work at home. And during the early stages of the pandemic, that was an incredible challenge because all of our supply lines were heavily impacted, either because they weren't producing or because everybody was looking for equipment. So it was mass amounts of looking for every piece of equipment we had throughout the hospital, doing inventories, talking to our friends, whoever we could get equipment from, and then making sure it was available to the right people. And then even enabling our call center from home, which again involved a VPN network, and masking the call center so that they can make calls from home but make it still look like it was coming from the hospital. And then finally, thinking about the technology to support the mobile testing sites that we were setting up quickly. You know, we did mobile testing sites in all kinds of locations like parking lots. And when you start thinking about how do you get computers and internet and Epic and printers and even phones into a parking lot and working well enough to treat patients, there's lots of logistics that need to be taken care of. And that was done in a matter of days by our incredible teams. So Dr. Anshul Pandey, who is our Chief Technology Officer, helped lead a lot of this work. And there is a popular podcast called This Week in Health IT, where they did a series of all the responses to COVID. And Anshul did one of those episodes. Highly recommend listening to that if you're interested in some of the details. But this is just a small sampling of the work that the teams were doing very, very quickly during the initial phases of the pandemic. Of course, telehealth and the technology behind telehealth was a major piece of the work. I'm going to let Dr. Pooni talk about most of the details around telehealth and the great work and research that she has led. But the technology piece was massive, and it just overwhelmed our systems, right? We had been doing a ton of work on telehealth prior to the pandemic. And we're really proud of our increasing numbers, but in a matter of weeks, we went from 20 visits a day to well over 800 visits a day. And so that kind of rapid expansion really tested our systems. We found out all kinds of issues when our systems had to manage those types of volumes. We had to quickly expand licenses, and then it really brought out of the woodwork some of the challenges with our previous system and the challenges with the workflow. And so in the middle of the pandemic, we ended up doing a major migration from one system to another, and really thinking about how to integrate it in the workflow. And with that, saw a huge improvement in quality and adoption. And I think the adoption piece really goes to both the quality and the way that we integrated it in the workflow, making it easier for providers to use this platform as opposed to some of the separate standalone platforms that were out there. And then also a huge cost savings. And, again, partly that's just in response to the pandemic. One of the industries that really came to the table was the webinar industries. And so all of a sudden everything was just different. And so it provided opportunity to kind of reevaluate our cost structure. But doing a major transition in platforms like this in a matter of months during a pandemic is quite a feat. This is another great paper. Like I said, across the nation, everybody was dealing with the same thing. So we were all, as a informatics community, talking frequently and publishing and sharing on listservs. This is a great paper out of Duke. And what I loved about this one is it really kind of highlighted the different phases of the pandemic. And this was early on, so I think they were definitely predicting the third phase, but we pretty much all generally saw in that first phase a major deployment of ambulatory telehealth in order to make sure that we were caring for our patients, but also minimizing exposure and encouraging social distancing. But after we kind of got those up and running, it became apparent that the inpatient setting was just as in need of innovative solutions. And we really didn't want to stick with the same structures where our patients, where our teams were close together and rounding in big groups, and where we were sending lots of people into patients' rooms who had COVID. And so there was a real rise in inpatient telehealth in that second phase. And similarly here at Stanford Children's, we found multiple different multiple different ways to use inpatient telehealth, everything from virtual multidisciplinary rounds where we could have case managers or pharmacists or other ancillary support staff join us virtually instead of standing there in a large group. This also enabled medical education to continue in a way when initially we didn't want to expose medical students, they could still join virtually. We did teleconsults with iPads, again, minimizing that exposure with sick patients, and remote family updates, teaching, since we didn't have as many providers in the rooms with the patients, all kinds of great work in that sphere. And then finally, before I hand it off, I'm just going to make one other quick touch on an issue that is really, really front and center for Stanford Children's and myself in particular. With the COVID pandemic and this move to virtual care, we just saw an exacerbation of the kind of challenges that we deal with in taking care of peds and adolescents virtually, and encouraging patient portal adoption and enrolling teens and children in patient portals, and then facilitating remote monitoring. And so there are some interesting considerations around children and teens in this space. And again, we have an amazing adolescent informatics group here that is really working through some of these issues. But just to highlight some of the things that are specific to pediatrics, one, we have to worry about proxy workflows. You're not just signing up the patient for the portal, you're signing up the patient's parent or guardian or proxy. And that can get really challenging, especially when you think about how do you confirm that the person actually has the right relationship to the child. In person, we assume that if a parent comes in with a child, that they are their parent, and that's how we know we can sign them up, and we can confirm the parent's identity, but we can't necessarily confirm the child's identity or that relationship. When you're doing that virtually, that all becomes a little bit more challenging. There really is no electronic method across the United States these days to establish guardian relationships. And in fact, when a foster parent becomes a foster parent, they have to walk into the hospital with a huge stack of papers to show that they're the guardian. And there's really no way to confirm teen or child identity. They don't have government licenses or identifications. They don't have credit cards, all the kind of the things that we use in the adult world. So there's a ton of research going on in this area, but it really is an interesting challenge. Similarly, adolescent confidentiality, how do we enable those virtual adolescent confidential visits without the parent knowing? And we need the portal for that. But again, how do you sign them up? Thinking about child data privacy and COPPA, the Children's Online Privacy Protection Act, which says that children can't have their own accounts until they're 13, amongst a lot of other things that it says. But again, that creates some challenges in how do you sign up a teen for a confidential account without getting their parents' permission. I already mentioned the confirming teen identity. And then when you get to the remote monitoring world, thinking about there's a lack of devices for young children. Children may not, often don't have their own phone for probably good reasons. But then if you're trying to do some of that monitoring using those devices, they don't have their own device. We use iPods or other tools like that for some of our young diabetics, but it is an ongoing challenge. And then finally, just segregating the parent and the child data when you have both the parents and the child's data on the same device. If you're using that parent's device for information flow back and forth, and how do you make sure that the parent's information goes to their chart in the EHR and the child's goes to theirs? So just some interesting considerations, a lot of work going on in this field, and this could be a whole nother talk in and of itself, but I will leave it there and pass you on to the interesting pieces. So with that, I'm going to hand it over to Raj to talk in depth about telehealth.
Great. I really appreciate the opportunity to talk a little bit more about telemedicine and our experience in pediatric telemedicine research. As Dr. Pageler alluded to, there have been a lot of changes over the last year in clinical informatics and healthcare delivery. One of the most important ways, in my opinion, many of our we were affected by this was that we saw, again, this dramatic increase in telemedicine. This figure comes from the CDC morbidity and mortality report from last October, which revealed on average there was a 154% increase in telehealth visits across the country. And although the increase in telemedicine over the last year due to COVID has been particularly impressive, prior to the COVID-19 public health emergency declaration, states, including California, had been incrementally introducing legislation regarding various telemedicine practices. So for example, legislation regarding store and forward data, need for consent of use for telehealth. However, a major national policy was the Health Information Technology for Economic and Clinical Health. And that's the high tech there highlighted in red, which was passed under the American Recovery Reinvestment Act. And this provided an impetus for the use of health information technologies, including the EHR, and improvement in interoperability. And then, as we know, the COVID-19 public health emergency, again, kind of rapidly accelerated legislation, telemedicine use, specifically in increasing permissibility for use of non-public facing video and text applications, so things like Skype, WhatsApp, amongst many others, and then introduced, of course, waivers for telemedicine. So some of you might be asking, why, as a pediatric rheumatologist, have I been really interested in telemedicine? And this has, again, kind of been a long interest of mine. And so I think the map on the left really highlights kind of where this started. To me, telemedicine represents an opportunity to reach patients that may be located in particularly remote areas where there aren't pediatric providers or pediatric rheumatologists specifically. And for the treatment of pediatric rheumatic disease, it's essential to have that connection and the ability to follow up, as many of our disease states are chronic. So the map here on the left shows, again, just how limited this access is, at least for pediatric rheumatology, and applies, again, to other fields as well, where here the blue states represent states where there may be one pediatric rheumatologist, or actually no pediatric rheumatologists. And then my initial research was really kind of understanding, what were some of the barriers in use of telemedicine in pediatric rheumatic care and how to potentially overcome them. The map on the right, kind of the how it's going, illustrates that although, there have been a lot of changes over the last year, specifically with COVID, that need still exists, that our patients are still kind of located all over. We still need to be able to provide care to them. So in considering the barriers to telemedicine use in pediatrics, we know that there are both technical and clinical barriers. In 2018, a division of the AAP, a Pediatric Telehealth Research Network, Sprout, found that some of the major barriers to startup or growth for telehealth programs included issues such as reimbursement, regulations such as licensing, but a big piece was also provider interest or provider acceptability of use of telemedicine in care. Kind of other literature has pointed towards, and experience has noted that patient acceptability, trainee education, being able to measure clinical outcomes have been barriers as well to the adoption and growth of telemedicine. Since the COVID-19 emergency declaration, I believe there's been a lot of movement with some of the more technical pieces. I mean, this is not to say that there still are not issues there, but obviously more IT resources, more training and support has happened as a result. However, much remains unknown about licensing requirements, reimbursement, and these are kind of things that have been in flux. If you're interested in learning more about the licensing requirements, if you just Google federal state licensing medical boards, there's a whole comprehensive list that goes state by state into details about that. But what I'm trying to illustrate here is that although there are ongoing technical issues, the clinical aspects, including provider acceptability, patient acceptability, health outcomes, trainee education, and then something that's really come to light during COVID, health equity, need really continued research and investment to understand how telemedicine impacts all of these things. So some of the work that I've done, and again with really great mentorship here at Stanford, was to start to elucidate some of those areas a little bit more in detail. So we actually did a study last year, really at the start of shelter in place, starting the last week of March and then ending the first week of May, over 4 pediatric subspecialties. So pediatric nephrology, pediatric endocrinology, orthopedic surgery, and rheumatology, where we looked at specifically areas regarding provider attitudes, patient perception, so through surveys and interviews. And then we also wanted to look at kind of the clinical exam piece, engagement. And so we actually collected some direct observational data from telemedicine visits. So with respect to provider attitudes and acceptability, we surveyed participating pediatric specialists regarding areas of clinical competence. And we found that the majority of providers were able to elicit the clinical information needed to make a clinical assessment. And we also found that nearly 3/4 of providers felt that they were able to complete at least some components of the physical exam in a reliable fashion. And, you know, this is applicable to all specialties, and I think it's been a point of concern in particular. This slide shows some of our results with respect to what was actually happening in the telemedicine visits. We found that both patients and providers were able to adapt telemedicine technologies to engage with each other in a way that may not have been possible actually in an in-person visit. So for example, there were multiple visits where patients were able to review medications with prescription bottles in hand, and providers could actually see how these medications were kept and stored. And there were even uses of the video platform for multidisciplinary providers to meet ahead of the patient before the visit to discuss the care plan. And so, you know, again, these are some novel uses of telehealth and telehealth technologies, and there's a few more that we were able to determine from the study. To shift gears a little bit, kind of the other major piece of our work really dealt with patient perception. And, you know, just to take a step back, in thinking about why this is important and why it's important for us in pediatrics, we know that, number one, child health is contingent on a caregiver or a parent's ability to provide care. We also know that higher parental and patient activation is associated with improved health outcomes, patient-reported outcomes, and quality of life in patients with chronic disease. We also know that parental self-efficacy, which has to do, so self-efficacy is like one's beliefs in being able to manage situations in their life, actually correlates, again, kind of with self-management, but also is related to health-related quality of life outcomes. And then self-efficacy in turn, and this is particularly important, again, in kind of pediatric chronic care or pediatrics in general, actually promotes shared decision-making, which we know may affect health outcomes. So we wanted to ask a lot of questions from our parents and our patients. And we wanted to, you know, ask what was positive about their telemedicine experience, what was negative about their experience, how were they able to adapt, how did it compare to an in-person visit, and how would they feel about integrating telemedicine in their child's care in the future. So first, what we did was actually, we did a couple of surveys just to understand domains of satisfaction and communication. And so we had all participants do a standard satisfaction survey, the VSQ9. And then we also did a second survey, the McCool Communication Assessment Tool, which reflects patient perception of provider communication. And there's definitely overlapping domains. And what we found is that parents and patients tended to rate areas of personal manner and respect more highly. We also found that the domains that were perhaps less favorably noted were more technical. So things like wait time and just kind of more technical pieces in that way. The next part of the study actually was, I think, the most interesting part. We interviewed parents and patients. Oftentimes it was actually a dyad interview. However, depending on patient age, if they were very young, it's hard to reel in a 5-year-old for a full interview. So oftentimes it was just the parent alone. And what we found was really insightful, and we were able to really elicit the true kind of parent perception around telemedicine at the time. So for the first quote here, you can see that we found interesting information regarding a value of telemedicine and monetary value. So the first parental quote here is, if it's like only $20 different, I wouldn't mind, rather than my child missing school a whole day and us traveling there. So it depends how much really. Again, monetary value assigned to in-person over a video visit. The second quote here highlights the connection with the healthcare team. I think we'd always prefer a personal visit as opposed to in person, assuming that there's no risk, just because it's a more connected way to see and talk with the doctor so-and-so. I think particularly for my child, it's more impactful and engaging. And then this last quote here highlights how patients may engage differently in telemedicine with their provider. So this teen patient said, "It helped me that this was a video-based visit because I haven't been very good about speaking about this in previous in-person visits personally, because my mom sat there in the room and I feel bad making a scene when my mom is sitting right there." So from all these interviews, we were able to compile the data, the interview data, and using qualitative methods such as thematic content analysis, we were able to identify the 5 key themes listed here and multiple sub-themes that were of topical importance to parents and patients. I think moving forward, we should continue to examine the impact of telemedicine on parental and patient experience with consideration of these domains. So again, value of telemedicine, both monetary and non-monetary, equivalence of telemedicine visits. Again, how does it compare to the in-person experience? Preparation, again, we're asking patients and parents to take on a new role potentially, and having new expectations and potentially need for additional guidance. Communication differences, and then pandemic-related safety was something that came up across the board. And again, this was very early in shelter in place. A lot of these patients were in pediatric specialty care, perhaps immunosuppressed. So I think generally at the time it was brought up kind of in the sense of it provided a feeling of safety, and everyone was kind of in an agreement with that. So though this study looked at telemedicine from multiple perspectives, there's clearly much more research to do moving forward. I think some of the key research elements to consider in the future include identification of appropriate telemedicine variables in relation to patient care and outcomes, consideration of how in-person practices may be translated to telemedicine in a standardized fashion. Particularly, this comes up oftentimes around the exam, for example. Evaluating clinical outcomes for telemedicine. Are there specialty-related outcomes that, again, need to be adopted in the telemedicine setting? How do we, for example, translate patient-reported outcomes in telemedicine, obtain that data as well? And then, of course, I had alluded to previously, the impact on health disparities is something that's really key. Again, my interest was in telemedicine is to disperse care in a more equivocal way and making sure that we're able to really reach patients. But certainly we have to consider how do we do this in an equitable fashion and make sure that we're truly able to reach all the patients. And then, I think overall, this is a really unique time because we have the opportunity to do this research and potentially impact policy, especially moving forward, but we need more data. And I just wanted to highlight here that many of our pediatric colleagues are actually doing some really great work in telemedicine already. Lynn Huffman has been working on telemedicine with respect to trainee education. Jen Carlson and Rachel Goldstein have been looking at the impact of digital care in adolescent medicine. Jeffrey Hart Cooper's been utilizing telehealth in a unique way to provide preventative care. So there's really fabulous work that's being done here. I did want to plug this monthly group that we have at Stanford Children's as well. It's called the Telehealth Provider Advisory Group. And basically it's a forum for providers from multiple specialties to come together, discuss telehealth issues, telemedicine issues, review research that they may have going on, works in progress. And it's also an opportunity to directly engage with the digital health team. Just wanted to say quick thanks, since I've had so many wonderful mentors, collaborators, and research colleagues for this work and other work. So thanks to everyone. And then these are my references, and I will pass it over to Dr. Longhurst.
Thank you very much, Dr. Pooni. I see a lot of familiar names on the panel today, and really excited to be here with all of you. I fondly recall all of my days at Stanford Children's, and I had to promise in order to present not to share any photographs, but I did want to say special thanks to Dr. Pageler for inviting me back, and for continuing the great tradition of the Clinical Informatics Fellowship. So it's now been 5 years since I transitioned down here to UC San Diego, and having a lot of fun, and that led to an interesting story during this COVID pandemic that I'll share quickly. And it's about these exposure notification systems. So hopefully you've heard about the CA Notify program in the state of California. I want to share a little bit about how that came about. So first of all, this started with this Apple Google exposure notification technology, which was announced in April and released in early May. And this was created in part as a response to some stories coming out of Southeast Asia, where governments were using location tracking technology to try to help contact tracing. And although in the long term, it turns out that those really did not help, because location tracking is not an adequate way to support contact tracing, it led to the development of this technology, first conceptualized at MIT, using Bluetooth to do proximity notification. So there's no location collected. It's all based on proximity to another user with a smartphone. So in this example, Bob and Alice might be high school students or college students. They don't know each other. In the picture, they're wearing masks. In reality, they might be on a party boat and spending some time together in the San Diego Bay, which is a story I'll share. Because they spend 15 minutes within 6 feet of each other, their phones exchange anonymous keys via Bluetooth. So there's no identifiable information that leaves your phone and no location tracking. And a few days later, Alice might test COVID positive. And because her test result is reported to the Department of Public Health, as are all of our test results in the state of California, she receives an automated text within about 24 hours that allows her to voluntarily move forward with anonymous exposure notification. And when she does that, anybody whose device who was close to her within a 14-day period prior to her testing positive will receive an alert suggesting that they may have been near somebody who tested positive. And so Bob gets this alert and he's directed to a website. So I became very interested in this after it was announced and released, and began advocating with various stakeholders in California. And over the course of the summer, got involved with our government relations folks, because there were actually proposed state bills that would have prevented us from moving forward with this, and in many cases based on some misinformation. So I drew on some lessons learned from my advocacy rotation as a pediatric resident with Dr. Lisa Chamberlain. And we had some great discussions with leaders in government and elsewhere about what this would mean. And that led to a pilot being announced September 10th. It was a joint pilot, UC San Diego and UC San Francisco. And we really pushed to launch quickly, because at UC San Diego, our ambitious chancellor decided to bring back more undergraduates than any other college in the state of California. So we had about 10,000 students move back onto campus in early September. The health system helped support all of their testing, and that gave us really an ideal environment to pilot this exposure notification. So we developed early outcome data that I'll share with you, but we got very high levels of adoption among our students, not quite so high among our faculty and staff, as I'll share. But we definitely confirmed that the early benefit of quarantining and testing using this. And that pilot then expanded in November to multiple other UCs. And finally, on December 7th, the governor announced the statewide expansion, which UC San Diego Health actually continues to support under contract. So if you go to this website today to learn more, canotify.ca.gov, you'll see that UCSD is actually running the website. We run the call center, some project management, and outcomes analysis. So there was actually a great article in the Stanford Daily in late December, and this QR code will take you to that article. But Athena and Jody, two Stanford undergraduates, asked some really good and hard questions about, how we knew from our pilot that this was worthwhile expanding. By the way, we were the 24th state in the US to expand this statewide, so right in the middle, and many more have come since then. But what I shared with those interviewers was, number one, we know that it worked. We had multiple anecdotal stories about students, and less so about employees, who were receiving exposure notifications and therefore quarantining and testing as a result of early exposure notification. Now, my hope was that I was going to be able to generate a positive predictive value of these exposure notification alerts and show, in fact, that they were, higher than your average sort of testing, of an asymptomatic individual. We weren't able to do that, and part of the reason is because this is so privacy preserving that there was very little data that we could collect, unfortunately. Even though UCSD Health did all the testing for this population, and we asked individuals when they tested if they were testing because they got an exposure alert, we had lowered the barrier so much, people could schedule tests online, and we just found that in many cases they weren't telling us when they were receiving an alert, launching an alert, et cetera. But the proof is in the pudding, and over the course of this pandemic, our on-campus student and employee positive rates have remained significantly lower than the community at large. And of course, we don't attribute that all to the exposure notification system. As I learned from Dr. Paul Sherrick, from a quality standpoint, this is a Swiss cheese model, right? The bundled intervention for quality improvement. And so this was a combination of wearing a face mask and physically distancing and washing your hands and adding CA Notify to your phone, and then regular symptom screening and asymptomatic testing for COVID. Now, I mentioned that our chancellor was extraordinarily supportive of this effort. He talked about this a lot, which certainly helped our adoption. But one of his goals was to actually show that campus could be a safer place for undergraduate students than hanging out at home and partying with their high school friends. And in fact, that's one of the things that our data did show, was that our on-campus students compared to our off-campus students actually were safer. And again, not just because of CA Notify, multiple reasons for that, but we certainly know that it contributed. The third key finding from this pilot was that the technology is really a health tool. And back to this issue of adoption rates, we as the employer, UC San Diego, were urging our employees to consider adopting this. And in our focus groups and a lot of outcome surveys that we sent, we found that there was suspicion of employers. Even though we're a university and we tried to be trustworthy, there's this lingering suspicion. There's also suspicion of the government and county public health and state public health. What we found, though, is when we extended this to our patients at UC San Diego Health, we had much higher click-through rates, much higher adoption rates. And we hypothesized based off our focus groups that was in part because people trust their healthcare provider in a way that they don't trust their employer or the government. And so our deduction was that messaging from a healthcare provider was particularly effective. And we've tried to translate that into our statewide go live by really partnering with health systems to encourage their patients to adopt. And then finally, compared to other states where the workflow for this code distribution was put into the contact tracing, we found that at UCSD Health, where we were testing people and then immediately notifying them at the same time that we were telling them that they might be COVID positive, that they could launch this exposure notification, that really moved this upstream compared to having it in contact tracing, which might be, 2 days, 3 days, even 4 days after the diagnosis of COVID, when far more exposures, may have occurred and exponentially increased. And so we became the second state in the country to do this automated code distribution approach. And we're still looking at ways that we might allow doctors and health systems to distribute these codes. So there's our data as of this morning. In fact, we've got our weekly call with the state this afternoon. We've got over 9.3 million users. Of course, remembering the Cerner conversions at Packard Children's and the Epic conversion, this is an extraordinarily large kind of go live, but frustratingly difficult to get the outcomes data because of the privacy preserving aspect that I mentioned. But we estimate this is about 24% of the population, or about 36% of smartphone users. And that's probably the much more important metric, because we know that teens aged 13 to 18 can use this and are often smartphone users, often meaning always. And we know that there's seniors and others who may not be smartphone users. And so what you see in this data is the amount of codes that are being issued. So you see around the Southern California surge in particular, very high level of daily codes being issued, codes triggering exposure notification. On average, every code triggers about 1.7 exposure notifications, meaning, if I voluntarily enter it, I might anonymously notify 2 other people. We've done some changing of the rules around exposure notification and liberalized it a little bit based on some of the latest science in partnership with the state public health leaders. One thing that we do know from our partners at Apple and Google is that we've had far more uptake on the Apple platform than on the Android. And that is somewhat concerning to us from an equity standpoint, because we know that Android users tend to be in the socioeconomic and healthy places index profiles that are probably higher risk for COVID. And so we've been doing a lot of work on outreach. You may have seen over the holidays, the road signs that sometimes, show Amber Alerts. We're showing CA Notify advertisements, and we've got it in all sorts of places, and worked on sort of outreach to these communities. But it's very hard to measure the efficacy of the outreach because, again, of our limited outcomes data. Now, United Kingdom launched this far before we did. They were early adopters last summer, and in partnership with Oxford University, they've done a lot of modeling and a lot of outcomes analysis. And they recently published, now this is a preprint, not peer reviewed, but it still, of course, got a lot of media attention, that based on 1.7 million, 3.1 million users reporting test results in the app, 1.7 million exposure notifications, and they estimated 600,000 cases averted in a 5-month period. Now, some of those cases may very well have been caught by contact tracing and other means that are more manual, but obviously this is an important augmentation and complement to traditional contact tracing methods, which work really well for sexually transmitted infections and things like that. They're much more challenging to do for respiratory diseases. So, of course, this is a pediatric audience, and the question is, what about children and adolescents? And I will say that we think adolescents is a particularly great group for this, because their transmission rates seem to be much closer to adults. And as we've helped at UC San Diego recreate the Return to Learn program from our university at local schools, this has been something that we've really pushed for high schools in particular. And so some of our high schools in the community have very high adoption rates of CA Notify. Of course, again, it's private and people don't know when it's being used, but our early outcomes data suggests it's been helpful in the high school setting. Now, for children under 13, most of which don't have a smartphone, it's a very different case. And so there has been some discussion with Apple and some development communities and others about different approaches that could be taken. And so recently, Canada, which was another early adopter, actually announced this wristband, which they are distributing 130,000 members at construction sites. And the wristband, interestingly, uses the same Google Apple exposure notification. So it can interoperate with somebody's smartphone if you're nearby, et cetera. It also has the addition of this LED light that blinks if a user is too close to another user. But this recording of contact information is done using the Google Apple API. And therefore is interoperable. And you could imagine something like this could be used for children under 13 if that made sense. And I think as these seminar series have been showing, the science in children under 13 is evolving. And so it's really a different kind of ROI calculation, but something to ponder. And I really believe that most of our outcomes data on these exposure notification systems are going to come to light as this pandemic comes to an end. But as Dr. Maldonado and others have remarked, yeah, this is probably not even the big one, and we're likely to see others. And so this is certainly something that can prepare us well for the next pandemic. So a lot of people to think, in particular, Dr. Carrie Byenting, pediatric infectious disease, who's also the executive vice president for UC Health in Oakland, as well as one of our LPCH graduates, Dr. Bronwyn Harris, who's been involved on the Apple side as well. And with that, again, I want to say thank you to my many mentors and pediatric hospital medicine colleagues and information services colleagues who I know are on the line. Love to hear from you. We'll stop there and I guess take some questions.
Awesome. Thanks, Chris. That's amazing work, and just incredible what you've helped catalyze across the state, and just carrying on your tradition that you started here. So amazing. In terms of questions right now, we have one question which goes back to that balance between I think adolescent privacy and parental involvement, and I will start with that one, and then Chris, would love to have you jump in if you have perspectives, especially on more on this piece. But this is an area, I think this question is is talking about healthcare in general, and of course all of these issues came into play with COVID. But this is an area that we are really fortunate at Stanford Children's to have a lot of expertise and really fabulous people working in the field. So actually Dr. Longhurst brought in Arash Anashiravani more than a decade ago, who is an amazing adolescent physician and started from some of our initial portal work here. And since that time, we've also had Jen Carlson and Rachel Goldstein, along with a large cadre of our fellows and other physician informaticists. Zalan Lee, our associate CMIO, has been heavily involved in this work. And really what we're trying to do is think about how do you empower families to take care of their children, and how do you also empower and engage adolescents and help them transition from pediatrics and being cared for to taking charge of their own healthcare. And it's a really tight balance, and it needs a very nuanced approach. And so we know that for adolescents to seek care around some sensitive topics like maybe mental health issues or drug use or contraception, that if they don't have that promise of confidentiality, they won't seek the care they need. So for those very sensitive topics, we want to make sure that they have a right to privacy and confidentiality and can get confidential care. Luckily, we are backed in California by state laws, which also support that idea and protect an adolescent's right to consent for those types of care and have privacy to the information around those types of care. And I'll say that while we are very fortunate in California to have that, the states throughout the United States, everybody has some variation on that, maybe not as broad as California's, but some variation. And so that's the type of care we try to provide for adolescents. But we know that for our complex, 12-year-old, 13-year-old who wants their parent and needs their parents' involvement, that the whole family should have access to as much information as possible. And so that's really the balance we're trying to reach. It's an interesting time right now across the nation because there is a movement to sharing more data, and there is a national law called the 21st Century Cures Act, which is helping to drive this, but lots of work to be done on that. Chris, anything you want to add in terms of those concepts, especially around the contact tracing?
No, I think you hit the nail on the head, and really appreciate all the terrific work coming out on adolescent confidentiality and patient portals and other aspects from Stanford Children's and your group.
Yeah, and I should note that Dr. Pooni, actually, her initial fellowship project during fellowship was looking at how she could engage adolescents. Dr. Pooni, you want to talk a little bit more about that project?
Sure. That was actually a really great learning experience. We basically, for that project, I was trying to have our teenage patients, number one, sign up for MyChart, become engaged with MyChart, and see if pushing out educational materials and trying to force them to engage in the portal would increase their transition readiness, which is really important. And again, kind of in chronic care, getting kids from pediatrics to adult care. I'm still working on that data, but I think the process really taught me a lot about some of the issues specifically with who is engaging actually in the patient portal, as you talked about, Dr. Pageler, with how do we delineate who has what access? Because what I actually found in signing many of these patients is that, I would ask the child to put in their email, and number one, kids may have emails, but they don't really check them regularly. They often have to look up their passwords. They have to, check with their parents what their email address is. So there's actually a lot of different kind of levels of, I think, patient data ownership, especially at that age, that maybe complicates the picture. But I think it was really interesting. I mean, all the patients were definitely very interested in participating and liked the idea, certainly, of being able to access their information in that way.
Yeah, I mean, it's great work that you did, and lots more work to be done. Thank you for sharing. And in our last couple minutes, there's a couple new questions, both kind of having to do with what you touched on, Dr. Pooni, was the kind of digital divide, health equity, and what that means in the context of telehealth. So one of the questions, we have the most diverse state in the nation, particularly with children. How do we adapt telehealth to help families with different languages, cultures, and varied resources? Do you want to take that one?
Sure. I think, we definitely have to, number one, make sure that care is accessible, that technology, which is, something that both Dr. Pageler and Dr. Longhurst talked about. But kind of the second step in kind of translation of care, I mean, definitely making sure, again, that we're language conscious, culture conscious. In pediatric rheumatology, there's definitely an effort to utilize parents and caregivers during the exam, for example. So we, have a pretty extensive musculoskeletal exam. So there's research being done on, number one, how to translate it, but how to do it in a way that, number one, parents aren't feeling too burdened by it, that they're able to do it. And certainly, again, kind of all those factors that Dr. Mendoza mentioned will also need to be factored in.
Yeah, I think we are just on the other cusp of trying to both measure the extent of the issues and figure out how to address it. And it's everything from the technical issues where people don't have access, and there is partnerships going on with companies across the nation to try to get better broadband internet access, which is a huge challenge in the U.S. But then to getting devices, to making sure that language is appropriate, to making sure that the cultural barriers or just the kind of hesitancy to join via digital is addressed. So we've got some amazing work. Again, Lisa Chamberlain here is helping to really lead a first step to just categorize and get data on this, but a huge area that we need to continue to address. Let's see, one last question. Has there been anything done, such as taking time, location data from EN and then distributing it to individuals who may have checked in on other apps like Foursquare, Swarm, Older Folks, Facebook, et cetera?
Yeah, thanks for the question from an anonymous attendee who also asked, some countries were mandating use of EN apps like Australia. Is there any specific data that supports EN playing a major role there? And again, what I would say is I think a lot of this EN data is going to come out post-pandemic. There is some early data from countries that were more aggressive, suggesting that it may have played a role in helping keep rates low. But in the United States, particularly given our privacy focus, we took a pledge at UC San Diego that many colleges have taken not to mandate the use, much to our chancellor's chagrin, who thought that it was a good idea. But I think that these are conversations that will need to occur post-pandemic as we prepare for the inevitable, next virus.
Awesome. Well, I think we are out of time. So with that, I will wrap it up. Thank you to our amazing speakers. And again, thank you to the entire committee who put this series together. It's been phenomenal. And thank you to the audience. We appreciate all the great questions. And I think all of us are happy for you to reach out to us if you want to talk more.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.